When I was in high school, one of my best friends was diagnosed with endometriosis. I remember her missing school at least once a month to deal with the chronic pain that came with the diagnosis. Her teachers and classmates seemed pretty unforgiving. She never got extensions or extra help for the time that she missed because most people just thought she was exaggerating to skip class. But from what I can remember, this was the first I'd ever even heard of endo. We were never taught about it in any general health class. Endometriosis is the most common disease that most people have never even heard of. Endometriosis affects society in so many different ways, so why isn't this a bigger issue? I decided to look into how the gendering of pain can be deeply problematic and how women's pain and endometriosis is a feminist issue. First off, what is endometriosis? It is defined as a chronic gynecological condition in which endometrial tissue grows outside the uterus. This tissue then responds to hormonal changes that are associated with ovulation, and during menstruation, it swells and bleeds. However, this blood cannot easily exit the body. Therefore, it causes severe, debilitating, and chronic pain. The disease can affect anyone with endometrial tissue, including transgender and intersex people. The causes of the disease are unknown, but researchers believe that it is due to some combination of genetics, blood system transport issues, direct transplantation, and transformation. There are countless personal stories about endometriosis. For example, filmmaker Shannon Cohn saw 17 doctors and specialists at world-renowned hospitals before one decided to look for endometriosis. They told her things like, maybe your pain tolerance is pretty low, or you're just trying to get attention. Dr. Linda Griffith had a similar experience when it came to her diagnosis. One doctor even told her mother that she was overreacting to get out of going to school. Kelsey Kupiak, a research student at SUNY Brockport, details her experience as the following. I remember placing my foot outside of the shower and immediately collapsing to the tile of my bathroom floor. I remember lying there, curling my body into a fetal position, bringing my knees to my chest to stop or relieve any amount of the pain that I was experiencing. I remember screaming as much as I could for my family members. I remember the IV, the morphine I was given, the sonogram, the CT scan, and so on. But most of all, I remember all the hours that I have writhed in pain in emergency rooms. Statistically speaking, endo affects 1 in every 10 women, which is about 190 million people worldwide. It takes an average of 8 doctors and around 10 years to get a definitive diagnosis, all the while these women are forced to live with debilitating pain. Researchers estimate that endo costs about $119 billion per year due to the loss of productivity, loss of work and wages, and medical costs. It's pretty clear that endo is a serious disease. So why is this the case? It all has to do with how endometriosis is socially, not just biologically, constructed. Part of why endo is not a more prevalent issue is because of the ways that it is diagnosed. First off, the only way to definitively diagnose the condition is through an invasive surgical procedure called a laparoscopy. This classification system for endo focuses on surgical diagnosis and ignores women's embodied symptoms, often conflicting with women's realities. This mode of diagnosis is highly problematic because it relies on quantitative data rather than qualitative reality and experience. Now, this is undoubtedly a form of scientism, the belief that science is the only reality, and it is detrimental to women's health. The disease is highly individual, and each person experiences different symptoms. Some people have painful periods, but others have GI, urinary, or immune system problems. Because of this, many people are misdiagnosed or mistreated for other diseases. The disease is often categorized as benign, as in non-cancerous. However, this term lessens the severity of endo and further silences the lived experiences of women with the disease. Because endo is non-lethal, this can also lead researchers to ignore it in their practice. Finally, many doctors aren't specifically trained to recognize endo symptoms, especially at the general practitioner level, which is where someone would go with initial symptoms. Endo requires the expertise of doctors in multiple different specialties who don't typically collaborate with one another. This is a limitation to doctors that we probably don't even realize. But the most significant reason for endometriosis being set on the back burner is that it is gendered female. Institutionalized biases in medical settings often act as barriers to adequate treatment for women in many different ways. First of all, endo is typically perceived as a fertility issue, which would inhibit a woman's ability to reproduce. In our current sociocultural landscape, women and their experiences are valued primarily for their childbearing purposes. Endometriosis is actually referred to as the career woman's disease due to the perception that a woman with the condition has neglected her childbearing duties. Another issue is that clinicians often think that endo pain is psychosocial and that those with the disease catastrophize their symptoms or are hysterical. This is the same reason that men wait an average of 49 minutes in an emergency room to receive treatment for abdominal pain, yet women wait 65 for the same symptoms. Women's authoritative knowledge of their bodies is constantly undermined under our current healthcare system, and as a result, their pain is downplayed and dismissed. Endometriosis has been historically presented as evidence not only of disordered female biology, but also of disordered personality and behavior, and we continue to allow this to deny medical intervention and reduce social support for women. Finally, the disease is thought of as women's troubles and is categorized as taboo. Because of this, many women don't feel comfortable discussing the very intimate symptoms that they experience with their healthcare providers. This also coincides with the paternalistic relationship between doctors and patients that we see in our healthcare system today. It's evident, especially in the case of endo, that doctors use their epistemological authority to assert their expert knowledge above women's embodied experiences. From a feminist perspective, the conversation surrounding endometriosis is relevant to agnotology, or the study of deliberate and culturally induced ignorance or doubt. In other words, willful ignorance. In this case, there is very clearly willful ignorance of women's lived experiences and authoritative knowledge. Women often don't feel supported in medical settings, or otherwise feel ignored or disbelieved, which leads to roadblocks to preliminary treatments and halts the process of attaining a more definitive diagnosis. We've also created a culture in which women's pain is normalized. Women are consistently taught to believe that menstrual pain is simply a part of womanhood, and since it is clinically and socially expected, clinicians often ignore it or write it off as unrelated. This also leads to the perception that women are somehow accountable for their own illnesses, as if there is no biological ground that contributes to their pain. Emma Wellen, a sociologist who specializes in morality in healthcare, defines this phenomenon as epistemological purgatory. She says, women are caught in a liminal space regarding the definition of their experiences and embodied knowledge about endometriosis in relation to expert knowledge. So, what are the consequences for this? There is an extreme lack of research into endometriosis, and it is largely ignored in government funding. And after all, health doesn't generate the same profit that illness does. It's also important to acknowledge that this issue of belief is exacerbated when it comes to minoritized women. Evidence shows that clinicians treat women of color as less reliable narrators of their pain experiences in comparison to white women. This silencing of Black and minority experiences leads to the misperception that endo is a white woman's disease, which creates a vicious cycle of incorrect narratives. And for transgender and intersex people, endometriosis is often disregarded as a diagnosis altogether. So, what are some of the effects of endometriosis? Endo limits several life activities, but since it is labeled non-lethal and gendered female, the chronic pain and social norms cause dismissal as feminine issues, which leads to multiple unnecessary problems for women with the disease. Some of these effects include increased chances of depression and suicide, psychosocial feelings of inferiority and incapability associated with the stereotypical role of being a woman in our society, and reduced social support due to disbelief. Finally, women are forced to live with chronic pain, but also with the perception that that pain doesn't matter. Largely because of the lack of research into endometriosis, there is no specific cure. However, there are a few inadequate treatments, such as surgery to remove lesions and drugs to tolerate pain and other symptoms. As recently as the 1980s, a common treatment was even to get pregnant. By stopping menstruation for several months, lesion growth could slow down and symptoms could temporarily improve. And if that isn't alarming, I don't know what is. A feminist solution to this issue might look like a combination of a few things. Currently, endometriosis is classified based on lesion count rather than symptoms, which discredits lived experiences. However, it is not one disease, and it shouldn't be categorized as such. We could move to a more pain-centric model of endometriosis, one that would change this classification system into one that takes into account the social influences on pain as well as the experiences of pain. We could also teach clinicians to focus on health and wellness instead of the disease and treatment, or provide opportunities for clinicians to become more conscious of social power systems and the intersectionality of gender, race, and class in healthcare. Finally, we must all recognize that women's health is socially and not just biologically determined.